Well, welcome everyone this evening to tonight's Wu University presentation entitled Top 5 What You Will Encounter in Your Retina Practice with Dr. Jolie Rodman. I'll be your host, Dr. Carolyn Major. And we want to give a special shout out to Eye Care for exhibiting and sponsoring the CE event this evening. And we could not have free CE without them. So thank you very much, Eye Care, for sponsoring tonight's awesome program. And just a few reminders before we get started with tonight's lecture. So for each hour of CE credit, you have to be online for a minimum of 50 minutes. And for a COPE certificate, you need to make sure you fill out the survey link in the chat at the very end of the presentation. It's also going to pop up once the webinar ends and the Zoom room closes. CE certificates are going to be delivered by email and sent to ARBO with OE tracker numbers. We're also going to display a QR code at the very end of the lecture. So if you have the OE tracker app on your phone, you can use that to snap the QR code so that you can get credit. You can't just use your regular camera phone. It has to be the camera through the OE tracker app. And CE certificates are going to be emailed within 4 weeks. And please make sure you ask questions throughout tonight's lecture because we're going to have a Q&A session at the very end. So you can ask questions throughout the lecture by using the little Q&A tab or the chat box down at the bottom if you're attending from your computer or laptop. If you're watching tonight through your phone or mobile device, you can also ask questions through the Q&A at the very top of the screen or access the chat using those three little dots in the bottom right-hand corner. And without further ado, it's my pleasure to introduce our speaker and my dear friend and colleague this evening, Dr. Jolie Rodman. She is chief of the Broward Eye Care Institute in Fort Lauderdale, Florida, and is a professor in optometry at Nova Southeastern University. She serves as the instructor of record for posterior segment disease at the college, and her research interests include OCT, OCT angiography, and vitreoretinal disease. Dr. Rodman has authored over 50 publications with an emphasis on retinal disease and is the author of Optical Coherence Tomography Atlas, a case study approach, the first reference book on this topic written by an optometrist. And Dr. Rodman is a member of the AOA, AAO, FOA, as well as the ORS. She's been the recipient of numerous teaching awards, was recognized as Primary Care Optometry News Top 300 Optometrists and Newsweek Best Optometrist. She lectures nationally and internationally and serves on the advisory board for numerous organizations. And so without further ado, I want to welcome you, Dr. Rodman.
Thank you, Carolyn. It's a pleasure to be here, and it's a pleasure to be here with you. So tonight we are going to talk about really the top 5 retinal diseases that you will encounter in your practices. And the reason that I love this presentation is, a lot of people think, oh, I work commercial, I'm not going to see a lot of disease in my practice. And I like to argue that that's definitely false, right? You can never work anywhere where you are not going to have disease. And so I wanted to talk tonight about the things that you likely in your career will see. So I have a lot of slides here. I'm going to talk through some of these pretty quickly because I don't think we're going to get to everything. But that being said, I did share all of my slides with Wu University, so they are yours to have. And if you have any questions on anything that we don't get to, please let me know. So I want to start off with one of my favorite topics, age-related macular degeneration. And why it's the first thing I'm talking about is when you look at the epidemiology or the statistics of how prevalent this disease is, it really makes sense that every single person watching tonight is going to see this in their lifetime. So we know that AMD is a significant cause of blindness, not only globally, but in the United States as well. It accounts for about 9% of blindness worldwide, and about 19.8 million people in the United States over the age of 40 are living with this disease. So these numbers are really mind-boggling. So if you tell me I have never seen AMD in my practice, I'm going to ask you, where are you practicing? Because certainly that doesn't make a whole lot of sense. Again, I'm going to go through some of these pretty quickly, but I think it's important to remember that when we're talking about AMD, AMD is a disease that really covers a spectrum of abnormalities. It starts off in the early stages, it goes into the intermediate stages, and ends, unfortunately, in the advanced stages where we suffer from either geographic atrophy or wet AMD. AMD is a disease of the outer retina. So when you're looking at the pathophysiology or a histological kind of slide of the retinal anatomy, we're looking really at diseases that affect the photoreceptors and south. My arrow is kind of in a weird place, but we're looking at this area down here and understanding the importance of how anatomy fits into this disease, because when you're looking at something like an OCT, you really want to understand what part of the OCT that you want to place emphasis on. It's not going to be super important to be looking at the sensory retina in a disease like age-related macular degeneration. We know that, again, looking at kind of an OCT scan next to an anatomical picture of the outer retina, we have our photoreceptor integrity line, which is this first hyperreflective band. We have the retinal pigment epithelium, Bruch's membrane, choriocapillaris. So this is essentially kind of the hot spot of where AMD is going to occur. And I'm going to talk very briefly about the pathophysiology of the disease and talk a little bit about geographic atrophy, which is a huge and fun topic that has really come to light in the last 2 years. So we know that AMD really begins with drusen. Drusen is the hallmark of this disease. Drusen is kind of that domino that sits at the front of the domino pack and sets everything in motion. Drusen live primarily between the RPE and Bruch's membrane. You can see it here on this anatomical picture and also on the OCT. We're looking at these homogeneous large areas where the pigment epithelium is lifted up from these large drusen deposits. The larger the drusen, obviously, the more obvious it's going to be on an OCT image. But keep in mind, it's important to use OCT or another imaging modality to look at the size of the drusen when we're trying to evaluate the stage of the AMD. So when we talk about macular degeneration, what are we looking at as far as risk factors go? Well, if you take an umbrella with 100% risk factor, 70% of that umbrella is going to be made up of genetics. So you can be doing everything right in your lifetime and unfortunately still get this disease because you have a genetic predisposition to this disease. So looking at that family history, right? Do you have a mother, a father, a sister, or brother with this disease? The other 30% is made up of physiological, contributors and lifestyle environments. When we look at that, we ask ourselves, what does that mean? Well, as the name implies, this is an age-related disease. It's really, age is the greatest risk factor for the development of this disease. We don't see this disease in young people. Being obese, having certain dyslipidemia. So the importance of understanding cardiovascular health, atherosclerosis, high blood pressure, that contribute to this disease and managing this disease with a primary care or internal medicine doctor. Smoking, right? We know that smoking is the number one modifiable risk factor. Talking to our patients about smoking cessation, diet, eating properly. So thinking about kind of, again, this umbrella and what we can do as physicians to modify the course of the disease in areas that we can modify, not genetics, but things specifically in the physiology and lifestyle and environment department. As far as pathophysiology goes, I mentioned before that drusen is really the hallmark of this disease. Drusen sets the dominoes in motion. And this slide was given to me many, many years back by a company called Maculogics. And I still use it because I think it's just such a perfect depiction of what the retina looks like if you were to kind of strip it down. So what you're seeing here are photoreceptors. This is your RPE, Bruch's membrane, choriocapillaris, and every part of the outer retina has a function. When everything is working properly, the anatomy is going to look superb, just like you see here. When we think about, again, that first sign that AMD is happening, we get what we call this cholesterol barrier or this cholesterol slick that forms between the retinal pigment epithelium and Bruch's membrane. And this cholesterol slick is essentially going to impede nutrient transport from the choroid into the overlying outer retinal features. And what ultimately is going to result is death of the tissue. The scary part is that fundoscopically, if you were looking at a patient that had this early cholesterol deposit, you wouldn't see anything. So this kind of emphasizes or talks to the importance of talking to our patients, understanding how we can modify the course of the disease, because a lot of these things are happening behind the scenes before anything even appears clinically. As the disease progresses, you can begin to see this build up, this is big slick of cholesterol, and look at the death of the tissue in the surrounding area. But again, you won't believe this, but you're still not going to see anything fundoscopically at this point. The first time that you're going to actually see something is when a drusen develops. And once we get to that point, look at how sick the tissue is. So really, if we're waiting until we see a clinically visible drusen, we've waited too long, right? We've waited to the point where there's so much damage that we really can't reverse it. So looking kind of at this again, this domino effect, you can see here that these are the stages here where we want to be modifying the disease and modifying the disease through proper education regarding dyslipidemias, obesity, exercise, proper diet, AREDs if appropriate, sunglass protection, things like that. Okay, so, disease classification to run through it quickly. I use the Beckman classification. The American Academy of Ophthalmology has another classification that's a little bit different, although, for the most part, they kind of say the same thing. But the Beckman classification breaks the disease down into four main branches. We have no AMD, early, intermediate, and then the advanced form. No AMD was really created particularly because we don't want to give every patient that has just a little bit of small drusen the diagnosis of macular degeneration. So, you're allowed to have some small hard drusen and not say that the patient has AMD. And I think really as a profession, we need to do a better job at making sure that we don't diagnose everybody with this disease. Early AMD, by definition, needs to have drusen that are about 63 to 125 microns. And you may be asking yourself, well, isn't that silly? How am I ever going to measure that clinically? If you look at the size of the central retinal vein as it exits the nerve, the optic nerve, that's about 125 microns in diameter. So you can use that as a visual cue that if you're looking at a drusen and it's about that size, we're kind of in that larger drusen category. You also shouldn't see pigmentary changes in the early stage because once the RPE is sick, we're going to be farther along in the disease process. Intermediate AMD, again, I'll mention that you'll get a drusen that's about 125 microns, and really you only need one of them. So looking at the fundus and identifying at least one large drusen or pigmentary changes puts us into that intermediate category. And then advanced, we know branches out into the dry geographic atrophy or the wet neovascular AMD. And this really just highlights, I'm not going to spend a lot of time on this, but it highlights really the importance of utilizing multimodal imaging when you're looking at macular degeneration to make a good diagnosis. And what I want you to take out of this slide is look at the difference and the OCT appearance of drusen as they grow in size. Once you're in that intermediate category, you can certainly appreciate that they become almost like drusenoid pigment epithelial detachments with these hyperreflective areas indicating those pigmentary changes that I mentioned before. Fundus autofluorescence is also a nice way to assess the health and integrity of the RPE and should be used in conjunction with OCT or color fundus photography. Again, this is advanced AMD, geographic atrophy, defined as this loss of tissue where you're visualizing down to choroid and sclera. You can visualize choroidal vasculature. And on the this side of the screen here, a choroidal neovascular membrane where there's evidence of bleeding. Here's just another nice image of geographic atrophy and really what it looks like on OCT, where you can see that loss or attenuation of the sensory retina and beginning of the outer retina as well. And then an OCT of wet. I'm not going to spend time on this. This is another lecture for another day. And as far as the wet AMD treatments, we all know that anti-VEGF has been extremely effective in treating wet AMD in patients that can't get an injection or maybe they've become tachyphylactic to it. Laser treatment can be used or photodynamic therapy. And we're fortunate that we live in an age now where new anti-VEGF treatments are coming out all the time. These medications are allowing injections to be spread out over longer periods of time. They're more efficacious. So wet AMD has really come a very long way as far as treatment goes. For geographic atrophy, briefly, because this again is a huge topic, we know that geographic atrophy is actually more prevalent than we think. When we look at these big cities like Philadelphia, San Antonio, San Diego, maybe even Manhattan, think about the population in these cities. And the crazy thing is that the population in these cities actually equal the number of people living with GA, which is about 1.5 million people. So we never believed that there were so many people living with this because really we were never looking for it. And I will tell you that this 1.5 million is actually an underestimate of the amount of people living with this disease. Most people remain undiagnosed. So again, crazy, crazy numbers. And the same thing I talked about before, utilizing multimodal imaging in your clinic to identify this disease so that we can intervene because now we do have intervention. So the treatments, it used to be, oh, we had nothing we can do for GA. We would talk about lifestyle modification, irid supplementation, and just pray that the patient outlived the disease. But luckily now there are two FDA approved medications. These are intravitreal complement inhibitors that delay the progression of geographic atrophy. So the home run or the take home message of this is that be on the lookout for GA, because we know now that the earlier that we intervene, the better off the patient's going to do in the long run. I'll show you quickly a case and then we're going to move on to the next topic. This was a 73-year-old male who came in for a comprehensive exam with some very vague complaints of some pinhole vision, pinhole black spots in his vision. His medical history was pretty unremarkable, but he was a smoker for 40 years. So that's very, very important, obviously, in the development of AMD. And he did have a family history of the disease. On quick glance, looking at his fundus images, I will tell you, and I've told this on every lecture I do this, and I show this case, I missed this first time around, thus emphasizing the importance of really using multimodal imaging. His right eye was 20/30, his left eye was 20/20. The left eye was really the quote safer eye. He had a couple of small slash medium, maybe one large drusen, which you can see on the OCT here, putting him into the intermediate, maybe early category. This was not the eye of concern. I mean, even though we want to keep an eye on it. However, what happened 1 year later? Look carefully at the drusen here and this area right here. This drusen actually collapsed and turned it into an area of geographic atrophy. So be very, very careful, because drusen collapse actually is an indication of early GA. And you can see it here on the fundus autofluorescence. So this is an eye that is a great candidate for intravitreal injection, because we don't want this lesion to encroach upon the fovea. And really, this is just showing you how the area up here, which was a little drusen, collapsed and turned into over here an area of geographic atrophy. But the right eye, which was actually the eye that I totally missed, actually had this very light colored area in the parafoveal region that I thought was, oh, maybe it's just, I don't even know what I was thinking, but I certainly wasn't thinking it was GA. I went ahead and did OCT, and you can certainly see this large area here of geographic atrophy. And I really just wanted to highlight here on the fundus autofluorescence how significant this geographic atrophy was. So not only was OCT an amazing tool, so was fundus autofluorescence. And so we got this patient over to Retina for intervention with the hopes that this lesion would not encroach upon the fovea. And he didn't have a great outcome because he stopped going. And you can see here that a year later, this area is now encroaching on the fovea, and this patient's vision tanked. He was 20/30, and I think now he's at the counting finger range, not particularly on this visit, but he keeps coming back and he's not doing very well. Thus, the importance, once again, of good education for the patient, working with a retina specialist that has the same beliefs as you, so we could get the patient where they need to be. And just the OCT there. This is a nice picture just of this example of over a 2 year period of time, how somebody with geographic atrophy might progress. It moves very, very quickly. It takes about 2.5 years for these lesions, these extrafoveal lesions, to reach the macula or the fovea. So be on top of this. That's the summary of this. Okay, topic number 2, diabetic retinopathy. So diabetic retinopathy, again, very powerful numbers. 38.4 million people in the US living with diabetes, which equals about 12% of the population. And diabetic retinopathy in itself affects approximately 30% of these patients. So another huge disease state. And I guarantee every person on this call tonight has seen a patient with diabetic retinopathy. As far as risk factors go, there's a lot. AMD maybe had a couple less, but this has a lot. We know that duration and blood sugar control are really the two big ones for diabetes. The longer the patient has the disease, the more at risk they are for developing retinopathy. And I emphasize to my students all the time that if you're not asking how long the patient had the disease, you're missing a huge or critical part of the case history or of the medical history. Blood sugar control. A lot of patients don't know their blood sugar. They don't know their A1C, but certainly ask it. We know, again, there's a very strong correlation between blood sugar control and the development of retinopathy. Other things, blood pressure, independent risk factor, smoking, another one. Smoking's bad for every eye disease. Race. We know that Hispanics and African Americans are more prone to getting this disease. Pregnancy, if you have gestational diabetes, you're more at risk, obviously, of developing it later in life as well. Obesity, other medical conditions, family history, genes, right? A lot of the same types of things that we talked about with AMD. For staging the disease, we all know this. I'll go over this very quickly. NPDR, PDR, diabetic macular edema. And just for a quick refresher, for those of you that don't think about this often, the AOA has pretty easy guidelines. So mild NPDR is defined as just microaneurysms. And then I usually skip over moderate and go to severe, which we know is the 4-2-1 rule, which means 4 quadrants of microaneurysms, 2 quadrants venous beating, and 1 ERMA. And if you have something in the middle of those two, then we say we are in the moderate category. So that makes it pretty easy to remember. Very severe is if you have two of the 4-2-1 criteria. When we ask the question, why does it matter? What does that 4-2-1 rule mean clinically? Well, if you think about it, it's important because we look at it as far as suggesting how often patients are going to go on to progress to PDR. So patients that have severe NPDR have more than a 50% risk of developing PDR in a year. That's huge, right? So these are patients that are setting themselves up for disaster in a very short period of time. Eyes with very severe have over a 75% risk. So these are really, really powerful numbers. The AOA also set forth guidelines as far as natural history, when to see patients back. So if you have a patient with mild NPDR, again, 1 or 2 or 3 microaneurysms, you can see them in a year. There's only about a 5% risk of progressing to PDR within a year. If they have moderate, 3 to 6 months is appropriate. And remember, each patient is an individual. So looking at their, how long have they had the disease? What is their blood sugar? What is their cardiovascular health, et cetera? There's about a 27% chance of developing PDR in the year. And then severe, we want to work alongside a retina specialist. That's what I would recommend. I would say alternate care, maybe every 2 to 3 months with a retina specialist. That way, if something does change rapidly, the patient is under the care of both physicians and will get treated as soon as possible. It's oftentimes hard to get a patient into a retina specialist. So if you're co-managing the patient, it's a lot easier than just calling cold. About a 50%, again, chance of developing PDR in a year. And just some examples, this is easy stuff for all of you. This is a patient with mild NPDR, a couple of microaneurysms, floating around here and there. Moderate, again, falls in between mild and severe. So we're looking for, exudates, more hemorrhages, maybe cotton wool spots. We know severe, we're looking for that 4-2-1, ERMA, venous beating, 4 quadrants of significant microaneurysms / hemorrhages. Some really nice pictures here of severe NPDR. You can see here 4 quadrants of hemorrhages. And remember that it's not enough to have, 1 hemorrhage in each of the 4 quadrants. There were standard photos put out many, many years back, which displayed how many hemorrhages you really should see in a quadrant to designate it as having severe. So it's important not to memorize, but to look back sometimes at those standard photos so that you're making sure that your diagnosis is appropriate. We all know proliferative is really defined as the development of new blood vessels, whether it be neovascularization of the disc or elsewhere. And then once we get into the high risk category, we're looking at very specific criteria. Tell my students that if you have a vitreous hemorrhage or a preretinal hemorrhage, you're in the high risk category. If you have NVD of a certain size, meaning it's taking up a significant amount of the disc, that's the other one that we're looking for. Kind of makes it easier for them to remember than memorizing. And here's some just examples. I'm going to fly through these of proliferative disease and really the high risk categories here. I just wanted to share this picture. Eye Care is sponsoring tonight, and I wanted to share this beautiful picture of proliferative diabetic retinopathy. I can't tell you how exquisite the resolution is on these cameras. I have multiple of them, and you can see here how beautiful. You can visualize the neovascularization right off of the disc here. I mean, it's just, I look at it and I said, this is just incredible photography. Here's another picture taken on their cameras of proliferative diabetic, right? Don't miss it. I mean, if you look down here, it was extremely subtle. This patient had some strings of neovascularization. Another one here. Really, really hard sometimes clinically to evaluate these things. And then we take fundus photography and we're like, wow, that was there. So hopefully everybody in here has an outstanding retinal camera that puts your diagnostic skills to shame, because these cameras certainly are better at diagnosing sometimes than I am. And then as far as, management, we went through this. This is just adding in here the proliferative disease. If you have a patient with proliferative, you want to refer within 1 week. If it's high risk, you want to refer within 1 to 2 days. Remember that if there is a tractional retinal detachment, you're referring immediately. Okay, so kind of keeping in mind those guidelines, that the sooner you can get the patient into the retina specialist, the better the outcome is going to be. Remember that diabetic macular edema refers to the collection of fluid in the macular space and can happen with proliferative, non-proliferative, any stage of the disease. So when we're marking in our assessment plan that the patient has diabetic retinopathy, really there's two parts to it. We're assessing, do they have, non-proliferative, what stage it is. Is it, severe or very severe? And we also want to assess the presence or absence of diabetic macular edema. So there's two parts always to the diagnosis. And we've really come a long way as far as diagnosing macular edema. It used to be that we use this term clinically significant macular edema, which we still teach for boards purposes. But I think that the way that most people are looking at things now is really using OCT, the OCT-based system, and identifying what we call center involving or non-center involving diabetic macular edema. And really the way we do it is we're looking at this thickness map, which is really based off of the ETDRS studies. And we're looking at the central 1 millimeter subfields. And we're asking ourselves the question, is the center 1 millimeter subfield on the thickness map abnormal? If it is, then that is center involving. If it's not, it's non-center involving. And really the importance of this is that patients that have center involving DME have a 10 times bigger chance of developing significant visual loss than patients that do not have center involving. So just an example here of an OCT-B scan indicating macular edema, and you're not sure, is it center or non-center involving. So get the OCT thickness map, and you'll see here that this is actually a center involving DME. And then this one here, this is more obvious, where the fluid pockets are way outside the macula, and this would be a non-center involving DME. Just another one with a center involving DME. And these pictures are again taken with the eye care camera, just exquisite detail. So here you can see the fluid, and again, the center involving DME. And so, anytime you have diabetic macular edema, you should refer. AOA guidelines tell us 2 to 4 weeks is appropriate. What I did want to throw out here, though, is there's something called the Protocol V by the DRCR, the Diabetic Retinopathy Studies, which really tell us that if you have a patient that has center involving diabetic macular edema and they have good vision, meaning better than 20/30 vision, most retina specialists are not going to treat. They're going to observe, because the studies told us that the outcome was similar between treated and untreated patients. So I would recommend, yes, you certainly can refer, but you don't have to be in a major hurry to refer if the vision is good, because the likelihood is that the doctors are not going to treat until the vision starts to get significantly worse. Now, if a patient is not a well patient and they have comorbidities, then that might be a patient that you want to get to the retina doctor sooner than another patient. And then again, center involving DME with poor vision, refer as soon as possible. I'm not going to go through these again. We're all, very familiar with anti-VEGF medications. Okay, moving on to retinal vein occlusion. So retinal vein occlusion is another one. I mean, if I ask any of you in the audience here, I'm sure every person will tell me that they at some point in their careers have seen some type of vein occlusion. This is the second most prevalent retinal vascular disease following diabetes. So just a huge presence in our clinics. It's super important that we take care of these patients properly, because there is a strong correlation between mortality and the development of a retinal vein vascular occlusive disease. Remember that when we talk about vascular occlusive disease, specifically retinal vein occlusions, we want to look at two things. Just like with diabetes, we were looking at the stage and also the macula. It's important when you're looking at a vein occlusion to not only look at the location, meaning is it the central retinal vein? Is it a branch retinal vein? Is it part of the central retinal vein, meaning hemiretinal? But also, is it ischemic, right? I think that we don't think about that often, but the chances of having a good outcome in a non-ischemic event is much better than if it's ischemic. So we need to really keep in mind that there's a lot of factors that go into making clinical decisions about these patients. Also keep in mind that retinal vein occlusions really, happen because of atherosclerosis of the adjacent central retinal artery. When you look at the central retinal vein and central retinal artery, they intertwine within the center of the optic nerve stalk. So if you have disease, if you have atherosclerosis of the central retinal artery, it's going to impact the central retinal vein. You're going to get like this clot or this thrombus that's forming, which isn't going to allow healthy blood flow to both come in and out of the retina. The most common reasons that we get vein occlusions, the number one and two reasons are microvascular disease, so hypertension and diabetes. And I've seen mixed literature about which of those is more common than the other. So if you see something, I think it's hypertension, but there's been some mixed thoughts on that. High cholesterol, cardiovascular diseases, anything that causes viscosity to the retinal vessels, so hyperviscosity, any of the inflammatory diseases. There's a big question with COVID. There was a lot of cases of retinal vein occlusions, miscellaneous things like different drugs, migraine headaches. And remember that if you have young patients, meaning less than 50, or patients that have bilateral disease, we oftentimes need to think out of the box and think about different systemic etiologies than the main ones. For ocular etiologies, the big two are ocular hypertension and glaucoma. Remember that anything that affects kind of that balance within the optic nerve head stalk or running through can cause a vein occlusion to occur. Other things that might cause different compression within the nerve, things like disc edema, disc drusen, tumors, abscesses, thrombosis, thyroid eye disease. So just some things to keep in mind when patients have differing things or more pressure happening within that small space. We know that patients complain of progressive, painless vision loss. Usually, they report, inferior or superior depending on what type of occlusion it is. And the visual acuity will vary depending on the type of occlusion. Just some great pictures here of central retinal vein occlusion. Here you can see cutoff of the central retinal vein, meaning there's backup of outflow in all four quadrants. You'll notice that real dilated. Look at the size of these veins. I mean, this picture is just so superb, really illustrating a beautiful central retinal vein occlusion. Look for, long-standing signs of disease such as collateral vessel formation, disc edema in the later stages, perhaps neovascularization, perhaps vitreous hemorrhage, perhaps neovascular glaucoma, depending on how ischemic it is. Remember that in the first 90 days after a vein occlusion, we're looking very carefully for the development of neovascular glaucoma. We call this the neovascular 90-day glaucoma. Hemiretinal, keep in mind, it's going to go nasally and temporally. That's how we differentiate this from a branch retinal vein occlusion. It's a hemispheric loss. Again, nasal and temporal distribution. Same thing, looking for the later stage of the disease. Branch retinal vein occlusion, we have the cutoff of blood supply of one of the branch retinal veins versus a whole hemisphere or a whole or the entire central retinal vein. If you're going to get one, this is obviously the safest one to get. But remember, just like we talked about diabetic retinopathy with macular edema, we always want to think about what's happening in the macula with any of these vein occlusions. So just collaterals again. Here's a nice picture of macular edema. So, when we talk about management of vein occlusions, remember that if there's no macular edema, the most important thing that we can do as optometrists is help to co-manage or refer out for good management of the systemic problem. The systemic problem is the number one thing. If a patient has macular edema, it's a referral to retina. You don't have to refer every single vein occlusion that you have, because what is a retina specialist going to do? If there's neo, that's a different story. If there's significant ischemia, that's a different story. But in most cases, the vein occlusions that we see, it's the kind of thing that we certainly as optometrists can manage, that is in our wheelhouse. OCT angiography has been a really nice way of assessing for ischemia. We talked before about, classifying not only which vein is cut off, but also looking for the level of ischemia. OCTA does a really nice job at showing us how much blood supply is cut off. And it's not, fluorescein, we know if it's 10 disc diameters, it's ischemic. It's a little harder with OCTA because we don't have as many quadrants to use, but certainly you can see the amount, these areas of darkness on OCTA are indicating areas there is no perfusion. So it's a nice way to assess the level of ischemia. So remember to always look at the underlying disorders. You want, get a CBC, test blood sugar levels, Look for any viscosity problems. Sometimes in the rare cases, think about the hyperviscosity syndromes. It gets more and more expensive as you go down the laundry list. Remember that for ocular problems, we want to reduce intraocular pressure because we know that that is the big thing with ocular risk factors. Just like everything I've talked about tonight, the earlier you get the patient to the retina specialist, if there is macular edema, the better off the patient's going to do. And I just mentioned here the two studies, the Bravo and Cruz studies, which really highlight the importance of early intervention. So the clinical pearl with vein occlusions is treatment of systemic conditions, whether it's diabetes, high blood pressure, or another systemic disease, is really mandatory to prevent further non-ocular life-threatening events. Remember, the patient's not going to be good for anybody if we don't take care of their systemic health, because we certainly don't want them to die from something that we could, identify through their eyes before anything serious happens. Okay, moving on to the next one, retinal detachments. So you will remember from your days in school that there are three main families or three main categories under retinal detachment. We have rhegmatogenous, which essentially just means that there has been a break, hole, tear, resulting in a retinal detachment. And just to remind you all, the definition of a retinal detachment is a separation of the RPE from the neurosensory retina. Okay, that's essentially, how we would differentiate it from ascesis, where we have a separation within the sensory retina itself. So looking at separation from the RPE and the sensory retina. Traction happens from proliferative disease, right? So we have something pulling tractional on the retina, whether it be proliferative diabetic disease, could it be sickle cell disease, something like that. A serous detachment, we see it with tumors, we see it with some of the Coates disease, areas where we have heavy exudation. That's where we see those. Certainly the most common type is rhegmatogenous, which I'm going to focus on for this little section here. So rhegmatogenous retinal detachments happen in about 1 in 10,000 people every year. So that's still pretty significant. Remember that rhegmatogenous retinal detachments are most common in specific patients. Patients with lattice, peripheral retinal breaks, if they're a high myope, if they've had previous intraocular surgery, if they've had trauma, previous RDs, or a family history of retinal detachment. And remember that not all RDs are created equal. So when you're looking at a picture of a patient that looks like this, and you have to ask yourself the question, when you're making a management decision, is this a macular on or macula off retinal detachment? This one is easy. This is a MAC on retinal detachment. So, MAC on is really a medical, we're going to talk about this, but we want to take these extremely seriously, because if this thing moves towards the macula, the patient's going to lose vision very, very quickly. This one, on the other hand, you can see that this area here is involving the macula. So this one would be a macula off RD. What if you're not sure? Here's a picture of a case. We think it's off. Maybe it's not. Maybe there's a piece of it that's still holding on for dear life. Use OCT if you can. You can see here, this one on the right is a picture of a MAC on, right? The macula is pinned down really, really nicely. But remember, this can peel off overnight. This one here, the MAC is off. So if you're not sure, if it's one of those cases where maybe I'm not sure, get other testing, maybe even get a B scan. Take a look at it. Here you can see a B scan of what or just a regular retinal detachment would look like, and try to use it for additional information. So as far as management decision goes, you're looking at a patient with a macula on retinal detachment. And I said before, this is an immediate referral, right? Doctors want to do surgery within 24 hours if possible. The earlier that they intervene, the better the patient's going to do. If the macula is off, we always want to refer as soon as possible, ideally within 24 to 72 hours. Ideally, surgery will be performed within 7 days. So, we want to get the surgery done as soon as possible, because if it's beyond the 7 to 10 days, that is when the outcome really tanks. So, it's super important, and I'm sure everyone knows here, when you pick up the phone to call the retina specialist and you tell them I have a retinal detachment sitting in my chair, the first question they're going to ask you is it MAC on or MAC off? And that's really because the management decision and the referral timeline is going to be dictated by that. For treatments, you guys all know this, laser treatments, cryo, different surgical procedures, topical meds, which is rarely done, and silicone oil tamponades. This kind of goes along with this family of the peripheral retinal disorders and really goes kind of hands in hand with retinal detachment. But when you look at this picture, what is the diagnosis? And you can see down here that there's obviously an abnormality. So this is a peripheral atrophic retinal hole, and I'm kind of lumping this together in the category of retinal detachments because really a lot of the risk factors are similar between retinal atrophic retinal holes and retinal detachments. The important thing to keep in mind is that atrophic retinal holes do not come from vitreous traction. They come from thinning. So if you think about a patient with lattice, a high myope, somebody that maybe has had trauma that's kind of messed up the anatomy of the eye, these are patients that are more at risk. They are not tractional in nature. So normally if we see a patient that has one of these asymptomatic, I emphasize, atrophic retinal holes, they rarely need to be treated. And that kind of goes along with operculated as well. Reasons to consider referral, reasons to consider surgical intervention would be if the patient's symptomatic, right? Always refer if they're symptomatic. If you see fluid, right? So in this picture here that I showed you, there looks like this whole area had a fluid. It looks like this is going to turn into an RD. Certainly refer. If the patient has had a retinal detachment in the other eye, bilaterality is always a risk factor. If the patient has a strong family history, if they've had prior surgeries, if they're an aphakic, a pseudophakic, remember when you start messing around with the vitreous, you kind of mess around with the retina. So you're always at risk. And being a high myope. The treatment could be laser, cryo, vitrectomy, sclerobuckle. You guys know all of these. Here's another patient, certainly has a lot of lattice. If you look really, really closely, though, you'll see that the patient also has some peripheral atrophic holes. So on that note, kind of going in the same category here, lattice degeneration found in 6 to 8% of the population. Remember, this is another thinning, peripheral retinal thinning disorder. Sometimes there's overlying vitreous liquefaction. There may be some adhesion to it. And again, a strong association with peripheral atrophic holes, retinal tears, retinal detachments. Here, you guys all know this. We'll go through this pretty quickly. Same idea as atrophic retinal holes. If you have lattice, most of the time we all know this, we do not refer. If the patient's symptomatic, if they have a retinal break, if they have something going on in the other eye, same risk factors, you can always consider referring. And the last thing we have is epiretinal membrane. And I kind of put it in the family of vitreomacular traction, although I would argue that epiretinal membrane is more prevalent than vitreomacular traction. And we all know that epiretinal membranes really form from anomalous PVDs. Okay, that's the majority of the time. The vitreous is trying to detach from the retina. Maybe it's not detaching, fast enough, or it's leaving some stuff behind, and an ERM happens. So we get proliferation of the glial cells, which live along the inner limiting membrane. So remember that the inner limiting membrane is the most superficial layer of the retina. The posterior hyaloid, as you can see here, is attached to the ILM. So if the posterior hyaloid is nagging at the inner limiting membrane, it results in this proliferation of the glial cell in like a sheet-like fashion. And really the whole thing with ERM is it leads to traction, right? So when you have ERM and it's tugging on the retina, that is when pathology can begin to happen. This is just another brilliant picture of an epiretinal membrane. Students oftentimes confuse these with exudation. So I would argue use OCT to help make a good diagnosis. You can see here this big, sheet-like structure over the macula here. For risk factors for ERM, really age is actually a very significant risk factor. So if you're older than 50 years of age, you have about a 2% chance of developing an ERM. If you're older than 75, it's 10 times greater, 20%. Okay, so the risk of developing an epiretinal membrane increases with age. It increases in people that have predisposing ocular conditions, and we'll talk in just a second about that. So in about 10 to 20% of cases, ERMs can be bilateral, but they, might be very significant in one eye and not so significant in the other eye. So here's again, a beautiful picture of an epiretinal membrane, but that's not all. So if you look really closely, you'll notice here that here's my epiretinal membrane. This patient has had a PVD, which is hanging out over here. But really the question is, what is this? And how many times can a camera just get this exquisite detail about what's happening in the vitreous space? So you guys could probably all know if I saw you live that this patient also has vitreomacular traction. And if you weren't sure, if you thought that maybe it was just part of the PVD, just part of the vitreous detachment, get an OCT. So what is vitreomacular traction? So VMT is defined as an anatomic obscuration. It is not normal, right? So incomplete PVD, vitreomacular adhesion, normal. But once you start changing the retinal anatomy and you have traction pulling on it, specifically within the 3 millimeter radius of the fovea, that is vitreomacular traction. And usually we see ERMs and VMTs kind of coexisting because ERMs are happening because of an anomalous PVD. So usually we see them together. And a lot of times, we all know this, we find them incidentally, right? They're not things that we're looking for. We're doing OCT maybe for something else, and we happen to notice that the patient has vitreomacular traction. So as far as risk factors go, VMT is most common in older adults and women, right? So you talk about women kind of in that 55, 60, 65-ish age. And really the reason is that we get a lot of age-related vitreous changes. We get early and advanced liquefaction, sorry, I'm saying the wrong word, because of declining postmenopausal estrogen. So estrogen actually has a protective role in keeping the vitreous intact. So when we go through menopause and we have less estrogen, this plays around with the vitreous. And if the vitreous liquefies too quickly, then the contraction and the liquefaction are not working in tandem. And when one outweighs the other, you get an anomalous PVD. So that is why we see VMT, ERMs so much more, or they're so much more common in elderly women or women in the postmenopausal years. Other things to keep in mind, again, same risk factors as we've been talking about: high myopia, uveitis because it's inflammatory, epiretinal membranes, diabetic macular. People ask me, why DME, why RVO, why diabetic retinopathy? When these diseases mess around with the retinal anatomy, any disease that messes around with the retinal anatomy can allow for changes in the overlying posterior hyaloid vitreous, which will maybe precipitate vitreomacular traction formation. This is my Valentine's Day VMT. Here's my little heart. You can see here that this patient's here's the posterior hyaloid with a very thick epiretinal membrane. And remember also that vitreomacular traction can come in many varieties. It can be focal, meaning it's very small. The points of attachment are less than 1,500 microns. It could be broad, where the points of attachment are farther apart. And in situations where it's focal, we worry more about the development of a macular hole. So just like every other thing I've talked about tonight, patient A might not equal patient B, and we shouldn't make a management decision on one or the other without doing ancillary testing. This was just a really cool example of a patient that, started off with very benign vitreomacular adhesion, right? You can see here, very benign vitreomacular adhesion. And so you bring them back in a year. What else are you going to do? They come back and they have really, really subtle vitreomacular traction, and you don't miss it. And remember, when I'm on that note, always go through your 21 lines, right? You're doing a 21 line raster. Make sure you scan through all the images because you don't want to miss it. Well, what do you think happened? Rightfully so. We said, all right, we'll see you back in maybe 6 months, maybe 8 months. Patient was asymptomatic. It was a random finding. And you can see here how the patient went on to progress. It looks like the patient might even go on to develop a macular hole, really depending on what happens with the vitreous. How much of that inner retinal tissue, how much is it going to take with it? So you could be doing everything right. You could be watching this patient carefully and doing everything right, and yet they may turn pathologic on you just because that's what happens. As far as management goes, these are the current standard of care. Really, if the patient is asymptomatic and you happen to be finding an epiretinal membrane, you happen to be finding VMT, you can bring them back in 3 to 6 months. You may decide you want to bring them back sooner, pending all of the risk factors that we talked about. Thinking about, is it focal? Is it broad? Thinking about what's happening in the other eye. Is it a male? Is it a female? All the things that we discussed tonight. But really, you don't need to be referring these, okay? If the patient is symptomatic, it's a different story, but asymptomatic ones in our wheelhouse completely. If the patient is symptomatic, you refer. You can refer, they'll probably do a pars plana vitrectomy with an epiretinal membrane peel. They may do pneumatic vitreolysis, which is where they do a gas injection to make a PVD happen, because remember that the vitreous is what's causing the tractional component. When to refer. So you think about it, you have a patient in your chair, they have an epiretinal membrane, maybe they have VMT. You don't know. Should I refer? Should I not refer? And this is a question that comes up all the time because we're all seeing so many epiretinal membranes. So think about these criteria, and I didn't make these up. This comes from the AOA, AAO. Decrease in visual acuity less than 20/60. Okay, so if patient, and that number varies. Some people say 20/40, 20/50, 20/60. That's a good place, right? So if they're around that vision, that's a good place to refer. If they have metamorphopsia, if they have double vision, is it progressing? Is it progressing rapidly? What's the status of their other eye, right? Use that other eye as a tool because remember that what one eye does, the other eye usually follows. And if you do refer, I talked about what the possible surgeries might be. There's about 80% of patients with ERM or VMT that are going to improve by at least 2 lines if you do send them for surgery. So just keep it in the back of your head that you don't need to be referring every single one of these patients. Listen to their complaints, use visual acuity as a means, explain to them that if they notice any change at all, obviously they come back immediately. So VMT will spontaneously resolve, and this is a huge statistic. I keep looking for something better that I can't seem to find, but 11 to 53% of cases are going to spontaneously resolve. So that being said, watch them, right? It takes usually about 15 to 18 months because the patient might just go away on their own. So watch them closely, but don't refer unless there's a good reason to refer. And I think we probably are, Dr. Major's back on. I think we're probably at time up here, but remember to also keep in mind, this is just an example of 2 different patients that had focal VMT, but they don't have the same prognosis. The patient on top is going to ultimately do much better than the patient on the bottom because look at the photoreceptor integrity line. It's fairly intact in the top patient, completely missing in the bottom patient. So the summary of this slide, and then I'll end, is make sure you're not telling every patient the same thing. What you tell patient A on top is a different story than what you tell patient B on the bottom because patient B on the bottom, even if this drops and spontaneously releases, their visual potential is never going to be as good as the patient that still has a healthy outer retina. With that being said, I'll toss it back over to Dr. Major. I think I got through everything, so that's awesome.
Kudos to you, Dr. Rodman. What an excellent presentation. Every time I hear you speak, I learn something, so I enjoyed it very thoroughly. And we had some excellent questions come in, so I'll just go ahead fire them at you. The first one is with regards to AMD. Do other forms of nicotine use also increase the risk of macular degeneration, or is it only smoking? Is one type of nicotine use worse than another?
My understanding, and Carolyn, you might know this better, have a better answer, is that I think they're all harmful.
Yeah. Should sunlight exposure be included as a lifestyle environmental risk factor for AMD?
So that's a great question, especially living in Miami here. I get asked that a lot. And the studies that I have found show that really you need to be in the sun for like 8 hours a day for it to be really bad for you. So, people that are working on the highway, fixing roads or on rooftops, and that's their job, and they're out in the sun all day long, they're at a significant risk. If you're living in the sun, you're living in a warm climate, yeah, I mean, we're at risk, but I would argue that if you're going in and out of your car and you're not sitting and sunbathing all day, that I don't know that you're at any greater risk than somebody that's living, maybe in Minnesota or something. So,
And at what level of geographic atrophy would you refer out for potential treatment?
yeah, I mean, that's, as you know, Carolyn, that's a huge topic. Geographic atrophy is a tough one. It's a conversation for, a big, big topic, but if you have we know that there are certain risk factors that are going to lead the patient to progress at a faster rate. So really quickly, because again, this is a big, big answer. If a patient has an extrafoveal lesion, meaning it's not involving the macula, those move pretty quickly. If they have multifocal lesions, meaning they have more than one, those are going to move more quickly than if they have one lesion. Um, Looking at a pattern on fundus autofluorescence, certain risk factors. But if you want to email me, I'm happy to send you a whole slide on that. But there are certain things that we should be looking for that are going to tell us if a patient is going to progress more rapidly.
Great. And any opinion on photobiomodulation in the treatment of dry AMD?
So I've heard some great things. Unfortunately, we don't have, I haven't used it personally. Photobiomodulation is supposed to play around with the RP and mitochondria to really get it back on its feet and help drusen go away, but in a good way. So I hear there's great things. I mean, Carol, I don't know if you have one. We have not used it. Obviously in Florida where it's a little bit tough, but great things on the horizon from what I hear. There's a lot of promise.
I hear the same. Do you refer non-center involved diabetic macular edema to retina?
So, non-center involving, I tend to watch, particularly if they have good visual acuity. A lot of times it's easier for these patients to come to us than go sit in the retina specialist office for 5 and 6 hours, at a time. I will watch them closely, and as I mentioned in the presentation, if they're a very sick patient and they have a lot of comorbidities, then I will try to get them into retina just because I know that they're going to move faster. But for the most part, my answer is that 99% of the time, non-center involving, I will watch closely. And at the earliest sign that something is turning south, I will refer.
Great. Um, and can you rely on visual acuity to determine whether a retinal detachment is MAC on or MAC off?
I would not. I mean, it's a great idea, in theory. You would think, yeah, if the patient's got MAC off, they're not going to see anything. But patients eccentrically fixate, they cheat. So I think you need to be careful. I personally wouldn't. I would rather rely on, an image if I can, an OCT if I can.
Yeah, I completely agree there. I feel like the retina can sort of like fold in front of the macula, or there could be vitreous hemorrhage or something else complicating the acuity
Yeah,
situation. Yeah.
100%. Yeah.
What factors do you take into consideration monitoring a patient on GLP-1 inhibitors, knowing that it can worsen diabetic retinopathy?
It's funny, on a side caveat, I was thinking this weekend, Carolyn, I need to make a new presentation. Like, what am I going to do? I actually just put together over Labor Day weekend a whole presentation on the GLP-1 drugs. So that's to come. But anyway, yeah, so that's a great topic. So we know that these medications drastically reduce blood sugar HbA1c in a very quick period of time. In turn, that causes rapid, I want to say, development or advancement of diabetic retinopathy. So these are patients that they're not going to stay that way, but yes, in the initial phases, the initial drop, they're going to go bad. But if they stay on it and they do well with their blood sugar and A1C, then they should revert back to normal. So I don't know if I answered the question, but that's a short period of time that there's going to be this significant rapid bad stuff going on, but then it should go back to normal. So I'm not sure if that answered the question.
No, yeah, I think so. And one last question. Does hormone replacement therapy treatment reduce vitreous degenerative changes in women?
So that's a great question. I don't have a ton of research, or I haven't done a ton of research on it. My thought is that if we could restore estrogen levels, that there should be a positive impact on that. But I don't have a research article to substantiate that. That's just my 2 cents. I'm not on hormone replacement. Maybe I should be. But anyway, but my thought is that it should. If you get the estrogen back where it was when we were youthful, then it should.
Great. Well, that's all the time we have for questions here this evening. Thank you so very much, Dr. Jolie Rodman. An excellent presentation as always. Really spurred a great conversation, a lot of great questions coming in. So thank you so very much for this evening's presentation.
Thank you all for being here.
And as we conclude here this evening, I want to remind you guys to join in for our next Woo You webinar. That's going to be September 9th with Dr. Quetting. That's going to be clinical applications of autologous serum tears in the spectrum of dry eye disease. So please make sure you register for our next free CE event.